All right, I'm going to go ahead and get started. Good evening, everyone. Thank you so much for coming. So for those of you who don't know me, my name's Stephanie Katartzis. I'm a PharmD resident here at Stony Brook University Hospital. And today I'm going to be presenting on throwing a curveball, the emergence of immunotherapies for refractory B-cell acute lymphoblastic leukemia in the pediatric population. And just a disclaimer before I start, I have no financial interests, arrangements, or affiliations with any organizations that could be perceived as a real or apparent conflict of interest in the content of this presentation. And any brand names that I mentioned throughout this presentation is only included for identification purposes only. So today's objectives are first to recognize the prevalence of B-cell acute lymphoblastic leukemia, or ALL, in the pediatric population. 2, to review the pathogenesis behind B-cell ALL. 3, to distinguish the mechanisms of the immunotherapies for refractory B-cell ALL. 4, to outline the common clinical manifestations of cytokine release syndrome. And 5, to describe the process of CAR T-cell therapy. Now, what exactly is ALL? So, acute lymphoblastic leukemia is basically a cancer of the early blood-forming cells. More specifically, it's a cancer of the blood and the bone marrow that is characterized by the overproduction of these immature lymphocytes, which are a type of white blood cell. And this kind of differs from the lymphoma cancer in that, well, as lymphoma does deal with white blood cells as well, these are usually localized to the lymph nodes, and leukemia usually originates more in the bone marrow and affects the bloodlines. And now for some epidemiology. So the reason I'm talking about pediatric ALL today is because it's the most prevalent cancer diagnosed in children in the United States. And about 1 of 5 cancers that are diagnosed in those less than 20 years old end up being ALL. The peak incidence does occur between the ages 2 and 5, and childhood ALL does develop a little bit more frequently in boys than girls, and that ratio ends up being about 55 to 45% respectively. But the good thing is that ALL does have one of the highest cure rates of all the different childhood cancers. So the 5-year overall survival rate is about 90% for children, and that's increased drastically from the 1960s when the overall survival rate was estimated to be just under 10%. And it's a little bit less too for adolescents and young adults because their 5-year overall survival rate is averaged to be about 61%. And now we're going to focus in on the pathophysiology. So there's 2 different types of acute leukemias. We have acute myelogenous leukemia, or AML, and acute lymphoblastic leukemia, or ALL. And the word acute kind of indicates that it's a very fast-growing cancer. And this cancer originates in the bone marrow, or the blood. And the bone marrow is that spongy tissue that's in the center of most of our bones that makes these blood cells. And then these blood cells mature into the more mature blood cells that get into our blood over time. So here I have this depiction of kind of what this process looks like. So as I mentioned, the bone marrow makes these blood stem cells. And this blood stem cell is the parent to all these other cells that we recognize in our blood, such as red blood cells, platelets, different types of white blood cells. And there's 2 different lineages here that we really focus on. So we have the myeloid stem cell that then grows and differentiates into the red blood cells, the platelets, and certain types of white blood cells. And then we have the lymphoid stem line, which becomes the lymphoblast and then further differentiates into either B lymphocyte or T lymphocyte or B cell and T cell. Now, acute lymphoblastic leukemia affects the lymphoblasts here. So this pretty much shows that there's a blockage in the differentiation of the immature cell, the lymphoblast, into becoming the mature B cell or B lymphocyte. So this blockage in differentiation ends up resulting in this overproliferation of these lymphoblasts or immature cells that are precursors to the B cells. And there's this overproduction of these lymphoblasts in the bone marrow that crowd out all these other bloodlines that are also in the bone marrow. So you might see less red blood cells being able to proliferate, as well as platelets and different other kinds of white blood cells because of this crowding out and infiltration from the lymphoblasts. So the presentation of patients presenting with ALL is kind of similar to related to how the infiltration of blasts in the bone marrow ends up occurring. So the presenting symptoms of ALL include bruising or bleeding due to thrombocytopenia or decreased platelets, pallor and fatigue from anemia, or infection caused by neutropenia. And they also may present with more constitutional symptoms such as fevers, night sweats, or weight loss. And then the labs coincide with that infiltration of blasts in the bone marrow, decreasing the other cell lines. We may also see elevated uric acid due to rapid cell turnover. On physical exam, a doctor may note some lymphadenopathy, splenomegaly, or hepatomegaly. And if there is CNS involvement with the ALL, patients may present with some chin numbness or facial palsy. And now we have our first patient case. So ML is an 8-year-old female with a past medical history of asthma, presenting to her pediatrician with several weeks of fatigue, easy bruising, and fever. Her labs reveal a white blood cell count of 60,000 cells, hemoglobin of 7, platelets of 26, and then the differential is there for your reference. So which of the following information is consistent with her diagnosis of acute B-cell ALL? Okay, yes, the answer is D, all of the above. So we may see leukocytosis from that overproliferation of those cancerous cells. We may have easy bruising due to the decreased platelets from those immature lymphoblasts infiltrating the other cell lines in the bone marrow. And then we also might see more blasts as a higher percentage in relation to all the other blood cells due to them replicating uncontrollably. So now these patients that come in with this specific presentation, how do they necessarily get diagnosed? So the diagnosis is mainly coming from a bone marrow biopsy in which there's a needle that is put into the back hip bone of the patient, and it goes into the bone marrow, and there's an aspirate that comes out that ends up being seen by light microscopy. And we usually try to count how many blasts there are or immature cells as a percentage in relation to all the other cells that are present. So acute leukemia is diagnosed with having at least 20% of blasts in their bone marrow. And usually patients with ALL present with an M3 marrow or having at least 25% blast or immature blood cells, because it's such a fast growing cancer that by the time they present with their symptoms and go to get their biopsy, the cancer has already been proliferating and brewing a little bit. And ALL can be found in the bone marrow, blood, testicles, or CNS. So there's different ways of risk stratifying patients based on different organizations and different institutions. However, for the sake of this presentation, I'll be focusing on the Children's Oncology Group approach. Patients with BALL are initially classified as standard risk or high risk. So usually patients that initially present with a white blood cell count of less than 50 end up being standard risk, because those over 50,000 end up being more, their cancer may have been progressing a little bit more, and we might have caught it a little later on, which is indicated by having such high white blood cell count. Children aged 1 to 10 years old are also standard risk. That's usually because they have more favorable cytogenetics in this age group that respond a little bit better to treatment and have the best event-free survival. BALL patients are also put in standard risk versus T-cell ALL, which is put more into the high risk category. Hyperdiploidy, which is having more than 50 chromosomes, also puts someone at standard risk because it's been associated with a better prognosis. And then having no CNS or testicular involvement also puts someone at standard risk, showing that the cancer didn't really spread there. And it's also harder for the chemotherapies to access those areas and penetrate them to kill the cancer in those areas. And also for high-risk patients, after they receive chemotherapy, especially their induction therapy, and their cancer is still present or their cancer went away and came back, that would put them at high risk. So a lot of these are major prognostic factors that are present at diagnosis that we can look at to help figure out how we're going to treat these patients and how strongly we're going to treat these patients. And genetic abnormalities and molecular subtypes also play a huge role in ALL. So ALL comprises multiple distinct genetic alterations, such as changes in the chromosome number, chromosomal rearrangements, and these mutations can affect key cellular processes that disrupt normal B cell development, including the regulation of lymphoid differentiation or even just cell cycle regulation. And the ones I want to point out for this presentation, one is the Philadelphia chromosome positive mutation that results in a BCR-ABL fusion protein. This has been associated with a poor prognosis. However, it's good to keep a lookout for it because there are more targeted therapies such as tyrosine kinase inhibitors that we can add to someone's regimen for their treatment to help target the specific genetic abnormality. And then the KMT2A rearrangement has also been associated with a poor prognosis, which is why infants less than age 1 have a poor prognosis, is because usually they present with this type of genetic mutation. So the identification of specific recurrent genetic abnormalities is really critical for disease evaluation, optimal risk stratification, and treatment planning. Now, how do we manage B-cell ALL? So there's 3 main phases that we see in regards to the patient's chemotherapies. First, we have the induction phase, which the goal here is to eliminate as many leukemic cells as possible from the bone marrow. We're really trying to crush and evacuate any cancer that's present in the body. And the goal is to achieve a complete response or remission, which is less than 5% of blasts or immature cancer cells that remain after induction. And this cycle usually lasts 4 to 6 weeks. Then we move on to the consolidation phase. And the goal here is to try to get rid of any residual leukemia cells that potentially remain after induction and can grow to cause relapse or cause the cancer to come back. And this is usually a 6 to 8 month period that is composed of 4 to 6 different cycles. And then we have the maintenance phase, and this is mainly here to help suppress any of the remaining cells that are there to ensure that they're properly proliferating and to prevent relapse as well. And this chemotherapy is a lot less intense than the other chemotherapy since we're mainly just trying to suppress any cancer that could pop up again. And this period usually lasts 2 to 2.5 years. And now the chemotherapy regimen backbone. So this is mainly here for your reference. Today I'll be focusing more on the immunotherapies for pediatric ALL. But just to look here, chemotherapy really is the backbone of pediatric ALL treatment to target the fast-growing malignant cells throughout the body. So we have our induction phase, and we can either give vincristine, corticosteroids, L-asparaginase, plus or minus anthracyclines in higher risk patients. And that just kind of shows you how important it is to risk stratify patients, because especially in the pediatric patients, we don't want to expose them to intense chemotherapies that can have lifelong toxic effects, such as cardiotoxicity from the anthracyclines, if it's not needed, and that they already have a better prognosis than someone who may require those intense chemotherapies. And we also, in the beginning, give them IT triple therapy or intrathecal triple therapy with intrathecal methotrexate, cytarabine, and hydrocortisone to help prevent any CNS relapse from occurring. And then there's different variations that can occur of the different chemotherapies listed here, but I just have this for your reference. And for relapse, so basically if someone's cancer goes away and then comes back, they are eligible for a hematopoietic stem cell transplant. But again, I'm going to be focusing more on the immunotherapies, but it's good to know that that would be one of the next steps if someone were to relapse. Now, what are immunotherapies? So immunotherapy is the use of medications to help a patient's own immune system recognize and destroy cancer cells. So it's a form of targeted drug therapy, meaning it's targeting a certain protein, a certain pathogen, focusing on specific or unique features of the cancer cells, as well as increasing the activity of your immune system to go fight those cancer cells. And this is more commonly indicated in relapsed or refractory acute lymphoblastic leukemia. relapsed meaning that the leukemia returns after a period of remission, and refractory meaning that the leukemia remains but does not respond to treatment. We also may need to preclude therapies with cytoreduction. And the different immunotherapies that are indicated in B-cell ALL currently include blinatumomab, inotuzumab, zogamicin, and tishigella-glucol. And this is just a snapshot too from the NCCN Pediatric ALL guidelines. And it emphasizes here that anyone with multiple relapses or refractory disease can then move on to either join another clinical trial, maybe involving a certain targeted therapy, different variations of chemotherapies, or blinatumomab, tishigella-glucol, and inotuzumab. And we want to achieve a complete response or remission so we can get these patients to a bone marrow transplant before they relapse again. Now, before I go into the different mechanisms of the immunotherapies, I'm just going to go over what exactly an antibody is. So antibodies are normally produced by our B cells in response to and counteracting a specific antigen, such as virus, bacteria, or any foreign entity. And then they identify them and neutralize them. And if you see here the structure I have, the antibody is usually shaped like a Y, and it has two different main regions, the FAB or the antigen binding region, as well as the FC or the constant region. And the antigen binding region has specific receptors at the end of them that help target a specific protein or marker that's on another cell. And the constant region helps alert the immune system to the antigen once the antibody binds to it. So they kind of tag the target for the immune system to find and exert their effects. And these antibodies are really targeted towards very specific proteins. So blinatumomab is a unique type of antibody. It's a bispecific T-cell engaging antibody that was FDA approved in 2014. And its common indications that it's currently FDA approved for include CD19 positive B-ALL in the first or second complete remission with minimal residual disease, positive in adults and children. And minimal residual disease, or MRD, is pretty much this quantification at the end of induction that's become a very important prognostic factor. So there's this molecular measurement of any MRD that was not detected by microscopy using either flow cytometry or PCR to detect leukemic cells that are not visible on a morphologic exam and try to assess treatment response and detect relapse. So the goal is to have an MRD of less than 0.01% at the end of remission induction therapy. And then blinatumomab is also indicated for the treatment of relapse or refractory B-cell ALL. And again, having that bridge to transplant where the goal is to attain remission and have the cancer go away just so the patient could get a transplant and avoid future relapses. Now going into its unique mechanism. So blinatumomab is really interesting in that instead of the normal antibody that has that typical Y shape, it has two different fragment antigen binding regions. So one end is going to target the cytotoxic T cells, so the T cells that do all the killing from our immune system, and link it with the other end, which the antigen target is the CD19 that is expressed on many different B cells. So it's pretty much bringing our own body's cytotoxic T cells directly to the cancerous cell so it can go ahead and kill the cancer cell. And since it doesn't have that FC or that constant region to call the immune system over, it relies on the T cell for that immune response. It's also less stable in our body, and it has a half-life of only 3 hours because it's missing that region. So it's usually administered as a continuous infusion. So overall, it directs our normal T cells to attack the cancerous B cells by bringing them close together with that linker. And there's different dosing recommendations for different indications, but both are consistent with a 28-day dose. So this is for minimal residual disease positive B-ALL. It's a weight-based dosing based on whether the patient weighs 45 kilos or more, they get a consistent dose of 28 micrograms per day. Or if they weigh less than 45 kilos, they have a BSA based dosing. And this is administered as a continuous infusion for 28 consecutive days due to it having such a short half-life. And after a few days of hospitalization, so the patient can be monitored, patients then go home with a small portable infusion pump and can be sent home with home infusion services. And this is the dosing also for your reference for relapse or refractory B-ALL. Again, we have that weight-based dosing, and this is just different in that it's titrated up to ensure tolerability. There's a little bit more of a disease burden with relapse or refractory B-ALL, so we worry more about the inflammatory side effects that can come from this immunotherapy. So we usually, again, start the patient off with hospitalization while they receive that therapy and monitor them, and then slowly titrate them up to get them to the 28 micrograms per day dose if they weigh over 45 kilos or 15 micrograms per meter squared per day dose. And some adverse effects we want to focus on for blinatumomab include first, neurotoxicity. It's a very important thing we want to watch out for. So looking for any encephalopathy, convulsions, speech disorders, tremors, insomnia. And then immune mediated would be cytokine release syndrome, which is a very severe reaction that I'll go over a little bit more. But generally, some other common ones we see could be pyrexia or fevers, hypertension, anemia, infusion-related reactions, or thrombocytopenia in pediatric patients. Now, this is a study that's looking at the effect of blinatumomab versus intensive chemotherapy on event-free survival among children with high-risk first relapse B-cell acute lymphoblastic leukemia. And this was a randomized controlled open label phase 3 trial looking at its efficacy, safety, and tolerability in comparison to conventional chemotherapy. Now, definitions of an event included relapse, death, developing a secondary malignancy, or failure to achieve complete remission. So looking at the results, the incidence of events in blinatumomab was statistically significantly lower than the high-risk consolidation chemotherapy. So this study concluded that among children with high-risk first relapse B-ALL, treatment with one cycle of blinatumomab compared with standard intensive chemotherapy before transplant resulted in an improved event-free survival at a median of 22.4 months follow-up. And now some clinical pearls for blinatumomab. So central venous access is required, kind of similar to other chemotherapies that we use. Hospitalization is recommended for the first 3 days of cycle 1 and first 2 days of cycle 2 for MRD positive B-ALL, or the first 9 days of the first cycle and the first 2 days of the second cycle for patients with relapse refractory B-ALL. And this is again to monitor for any signs of cytokine release syndrome. Blinatumomab is a low emetic regimen, which is important to note. However, we do still premedicate with dexamethasone for trying to prevent cytokine release syndrome. So we give dexamethasone before the patient's initial dose, or if their dose is being titrated up, we give it every day that the dose would be titrated up or increased. And if the continuous infusion stops for more than 4 hours, then we would also give dexamethasone before reinitiating the infusion. Now I'm going to go more into cytokine release syndrome. So since we're bringing our T cells and our immune system directly to the cancerous cells, this can invoke an immune system response that is too powerful or too strong. And there's this large rapid release of cytokines into the blood from the immune cells affected by the immunotherapy. And this can be life-threatening or fatal. And doctors can consider either interrupting the therapy or even discontinuing the therapy based on its severity. And this cytokine release syndrome can occur within minutes to hours of the BiTE therapy, but usually within 24 hours is when we see it most commonly. And this can manifest as either fever, nausea, chills, or even more severely, hypotension, tachycardia, headaches, myalgias, dyspnea. And CRS can also cross into the CNS and cause some neurotoxicities, which we do worry about as well. So if you see in this little depiction here, basically the T cell is invoking this huge immune response and all these pro-inflammatory cytokines are released, causing this systemic reaction. So cytokine release syndrome management is usually based on the grading severity. We have more commonly the CTCAE, or common terminology criteria for adverse effects, that has different grading, grade 1 to 5, grade 1 being a fever with or without more constitutional symptoms, to grade 5 being death. And then grade 4 would be more life-threatening symptoms that the patient has. There's also the UPenn, University of Pennsylvania, or the Children's Hospital of Philadelphia grading for CRS. And the reason I bring up there's two different scales is because the management may differ a little bit slightly depending on the scale used, but more commonly we see the CTCAE scale grading severity. And since the immune system's going on overdrive, the best way to treat it is to try to suppress the immune system. So that's why we have our corticosteroids to help reduce this T cell activation and anti-inflammatory effects. We may also use tocilizumab, which helps block the immune cell activation from interleukin-6. And interleukin-6 is one of those big culprits in cytokine release syndrome that really does invoke very strong inflammatory responses. However, if the CRS does cross the blood-brain barrier and affect the CNS with those neurotoxicities, we do need to treat with dexamethasone because tocilizumab does not cross the blood-brain barrier. And these are the dosage modifications recommended by the package insert and manufacturer. So they use the CTCAE scaling here. And grade 3, they recommend the patients interrupt the blinatumomab infusion and administer dexamethasone with a taper. And when the CRS is resolved, we can restart the blinatumomab, but at a lower dose and escalate it after 7 days if the adverse reactions do not recur. However, for the more severe life-threatening grade 4, we want to discontinue blinatumomab permanently and administer dexamethasone as instructed earlier. And now looking at inotuzumab ozogamicin, this is the next immunotherapy that we'll be speaking about today. And this is used and FDA indicated for the treatment of relapsed or refractory B-cell ALL in adults. It's not currently indicated in children. However, there are current studies that are going on, as well as some retrospective studies that I'll go over, which really show that it has a great effect in the pediatric population as well, and is pretty well tolerated. So this is definitely in the pipelines to be probably another indication may be added for pediatric population in the near future. But this medication is interesting, and that is the CD22 directed antibody drug conjugate. So its mechanism is in its name. So it's an antibody that's targeting the specific CD22 protein that's found on B cells, as well as having this drug conjugate, this calicheamycin, that's a DNA damaging agent that's attached to it. So the antibody goes ahead and binds to the cancerous tumor cell with the CD22 and gets internalized. And once it's internalized, it releases its calicheamycin to go ahead and damage the DNA so that the cell can't replicate, and there's apoptosis, in which the cell results in cell death. So some adverse effects we worry about with inotuzumab are listed here for your reference, but I definitely want to emphasize the hepatotoxicity, which does have a black box warning for inotuzumab, more specifically sinusoidal obstruction syndrome, or SOS. So the hepatotoxicity is in the form of hyperbilirubinemia, transaminitis, and this sinusoidal obstruction syndrome, which is a result of injury to the hepatic endothelium and liver cells, resulting in this accumulation of blood cells that obstructs the sinusoidal flow, causing liver damage and some hemorrhagic necrosis. This is formerly known as veno-occlusive disease. And we want to try to avoid any concomitant hepatotoxic medications such as azoles. In some patients, we may consider the use of ursodiol for prophylaxis. And these patients can present with abdominal pain, swelling, weight gain, ascites, or jaundice. And some clinical pearls for inotuzumab. It is a lot shorter of an infusion. It's only a 1-hour infusion in comparison to the 28-day long infusion with blinatumomab. And we try to pre-medicate patients before they receive this infusion with corticosteroids, antipyretics, and antihistamines to help prevent any hypersensitivity reactions. We also want to monitor liver enzymes, just like bilirubin or LFTs for SOS. And it's also important to note that there are some drug interactions with this medication. We want to avoid the use with CYP3A4 inhibitors. and also watch for any other QTC prolonging meds, since this medication can prolong the QTC as well. Now, this is the retrospective cohort study looking at inotuzumab in pediatric patients with relapsed refractory ALL. So since there's no prospective studies that have been published, the manufacturers ended up looking at their use within the compassionate use program for pediatric patients receiving this inotuzumab. So data was collected from 30 different international pediatric oncology centers, and they found that the complete response or remission was achieved in 67% of patients with overt marrow disease. And the majority of these patients were also MRD negative. And this study concluded that inotuzumab was very well tolerated and was an effective therapy for children with relapsed ALL, and that prospective studies are warranted. And those prospective studies are currently going on today. So now for our next question, I have, which of the following laboratory markers would you monitor for in someone receiving inotuzumab ozogamicin? A, their magnesium level, B, liver function tests, or C, CD4 count, or D, serum creatinine. Okay, so here the answer is B. We want to watch the patient's LFTs to help prevent or watch out for sinusoidal obstruction syndrome. And now we're going to move on to the CAR T-cell therapy. So this is a novel therapy that uses adoptive cell transfer. And that just means that there's this transfer of cells derived from our immune system that go directly into a patient. So patients' own white blood cells, more specifically their T cells, are collected and genetically modified to target a specific leukemic cell surface antigen. And that receptor that they add on is called the chimeric antigen receptor, the CAR, which is in its name. And there's also different co-stimulatory proteins that are added for smoother activation of the T cell and prolongs this T cell activation so that it can last longer in the body. So by enhancing the T cell proliferation and cytotoxicity, you can see here I have the different CAR T cell generations that ranges from first generation to fifth generation. And the fifth generation CAR T cells showed low cytotoxicity and proliferation, which is why they added on these different components to it. So it's really interesting in that the T cells are really just multiplied in the lab and given back to the child's blood, where they can seek out the leukemic cells and attack them. And now I have this video from Dana-Farber Institute, which kind of goes into this mechanism a little more.
If it's working properly, the immune system wants to kill cancer cells. That's its job. Create an army of T cells to patrol our body for signs of infection and other diseases. The T cells inspect suspicious cells and, when they find an abnormal one, immediately lead an attack on it, while limiting the damage to healthy cells. The way they do that is pretty elegant. T cells have protein receptors on their surface, and these claw-like structures latch onto antigens, protein fragments found on the surface of all cells. When a receptor latches onto an abnormal antigen, like one found only on a diseased cell, the T cell turns on and releases toxic chemicals that damage the abnormal cell and recruit other immune helpers to the area. Sometimes cancer cells develop ways to fool the immune system, either by disguising themselves as healthy cells or by sprouting so many antigens on their surface that the T cells are stymied and can't mount an effective attack, or by finding ways to turn off the immune response against them. One innovative way to see through the deception is CAR T-cell therapy. Thousands of a patient's own T cells are collected in a process similar to a blood donation. Using a modified and inactive virus that can't cause any disease but can introduce genetic information into a cell, the T cells are reprogrammed so they now produce special receptors called chimeric antigen receptors, or CARs, on their surface. These newly engineered cells, called CAR T cells, are grown in a lab, and millions of them are infused back into the patient. The new receptors enable them to latch onto a specific antigen on the patient's tumor cells and destroy them.
Okay, so just to kind of summarize what that video went through. So patients' white blood cells are collected from them in a process called leukapheresis. And these harvested white blood cells then get frozen and sent to the manufacturing facility. And at the manufacturing facility, they separate out the T cells from the white blood cells. And the cells are genetically engineered with a virus vector that gets into the cell and genetically modifies it so that it targets the cell surface tumor-specific antigen to recognize and fight the cancer cells. So in tisagenlecleusel's case, we target the CD19. And after they genetically modify these cells are give time to be multiplied and expand, and then these T cells are frozen again and shipped back to the patient, in which the patient gets their own genetically modified T cells re-administered. And this process does take several months. So talking more specifically about tisagenlecleucel or Kymriah, it's a second generation CAR T cell therapy that generates a response against the CD19 marker, similar to blinatumomab. And it was FDA approved in August of 2017. And it's FDA indicated for patients with relapsed refractory ALL who also are up to 25 years old. It's given as a short infusion after some conditioning chemotherapy, and it does have an effect that peaks at 1 to 3 weeks. And it doesn't have the typical milligram dosage that we may usually see. The dosing is usually total positive viable T cells, and the dosing depends on the weight under or over 50 kilos. Our institution for the pediatric population does not have this CAR T cell therapy available, but usually institutions would order it through the blood bank, or the pediatric patients here who are eligible might need to get transferred to nearby hospitals such as Cohen Children's Hospital or MSK, who are able to perform this therapy. But now going into the literature, we have tisagenlecleucel in children and young adults with B-cell ALL, and this is a phase 2 open label multi-center global study of tisagenlecleucel, but in those with relapsed or refractory B-cell ALL. There are 75 patients, ages ranging from 3 to 24 years, who received this CAR T cell infusion. And the overall remission rate within 3 months was 81%. And that's pretty significant, since a lot of these patients were refractory to previous chemotherapies or kept relapsing, or received targeted therapies that failed. So being able to have an overall remission rate of 81% is pretty impressive. And tisagenlecleucel, being a second generation CAR T cell therapy, was also in the blood for a very long time. It was observed for as long as 20 months. So this can also help us determine that it can be more beneficial to help prevent relapse, since if any cancer tries to form while this CAR T cell therapy is in the body, it's going to get nipped in the bud by the tisagenlecleucel and not be allowed to grow and cause relapse. So this persistent effect it has is very important. A downside to this CAR T cell therapy, though, is that there was cytokine release syndrome, which again we saw with blinatumomab, that comes from these immunotherapies, and it occurred in 77% of patients. So CRS does become more severe and more frequent with CAR T cell therapy. In this specific study, about 48% had to receive tocilizumab, and about 47% had to be admitted to the ICU for management of the CRS syndrome with more intensive care. Some patients had to receive high-dose vasopressors or oxygen supplementation as well. So this is a very severe reaction that can come with this CAR T cell therapy. But overall, the study did conclude that a single infusion of tisagenlecleucel provided durable remission with long-term persistence in pediatric and young adult patients with relapsed or refractory B-cell ALL with transient high-grade toxic effects. So the previous study that I just mentioned implemented a grading scale for the cytokine release syndrome that was developed at the University of Pennsylvania and Children's Hospital of Philadelphia, as well as defining CRS management algorithms. So I have this algorithm here. So we want to pre-treat these patients who receive this CAR T cell therapy with any acetaminophen, diphenhydramine, and antihistamine, as well as monitor for any prodromal syndromes or symptoms such as low-grade fevers, fatigue, anorexia. We want to observe these patients at that point and try to rule out any infection, maybe get some surveillance cultures or empiric antibiotics if they have febrile neutropenia. But mainly, initially, we're providing symptomatic support. So we can provide some oxygen, fluids, low-dose vasopressor support if there's more severe hypotension, or antipyretics for the fevers. Now, if this CRS tends to worsen or just not get better with the symptom management, we would escalate to using tocilizumab. So the tocilizumab is infused over 1 hour, and it's also weight-based dosing, depending on if the patient is 30 kilos or more or under 30 kilograms. And if they still don't improve, then we would consider steroids. Now, if there's no response to the steroids within 24 hours, we can consider a second dose of tocilizumab. And if we do give steroids and they get more hemodynamically normal, then we can consider rapid tapering down the steroids, because the steroids can affect the efficacy of the CAR T cell therapy, which is why initially we do not pre-medicate with any steroids to help prevent CRS like we do for blinatumomab. And now if their picture tends to clinically worsen or just not get better, then we can consider siltuximab, which is a direct interleukin-6 inhibitor. And if that doesn't work, then we can go all the way up to consider anti-T cell therapies such as cyclophosphamide, antithymocyte globulin, or alemtuzumab. And those would, again, affect the efficacy of the CAR T cell therapy by being anti-T cell therapy. So that's why it's one of the last line managements for CRS. And now we're going back to our patient case with ML. So ML grew up a little bit. Now she's a 10-year-old female with a past medical history of asthma and B-cell ALL status post multiple relapses. She was enrolled in a clinical trial to receive blinatumomab and is currently cycle 1, day 8 of the infusion, in which her dose of blinatumomab was titrated up. 8 hours into the infusion, she reported headaches and severe myalgias. Her temperature was 38.1 degrees Celsius, blood pressure 90/64, and she was deemed to be grade 3 on the CTC-AE for cytokine release syndrome. Now, how can we best manage ML's current state? Okay, so the best answer here would be A, to administer dexamethasone. So since our immune system is going on overdrive from the blinatumomab, the best thing we could do is help suppress it with the steroid, more specifically dexamethasone. And now to sum up everything. So ALL is the most prevalent cancer in pediatrics. Although it has pretty good overall survival, there are some patients who relapse. And once a patient relapses, they're at higher risk for relapsing again. So that's when these immunotherapies can come in to help bring the patient into remission if they relapse and prevent either relapse or try to get these patients into receiving a bone marrow transplant. So we have the BiTE therapies, or the bispecific T cell engagers, that bring the T cell directly to target antigens on the cancer, more specifically the CD19. We have the antibody drug conjugates, which targets leukemic cells, then releases the toxic agent to the cell. For CAR T cells, we use the patient cells that are programmed to target antigens on the cancer. And the toxicities here are mainly caused by immune system overactivation. So the management would be involving immune suppression. So thank you everyone for coming. I'd like to thank Tyler, Amanda, and Caesar for helping me put this presentation together. If you have any questions, please let me know or put them in the chat.